I'll briefly mention the value of endometrial thickness as a surrogate of endometrial function. Then I'll show you a few like stunning examples of endometrial measurement. I find them stunning, really. And then we'll review what is the predictive value of endometrial thickness in ART cycles. And if you end up in believing that endometrial thickness matters, then what are the options for treatment? Okay. So if you read any paper about embryo implantation, they always start with, phrases like embryo implantation is a complicated process that requires, harmonization of this and that, et cetera, et cetera. I mean, it's true. Actually, it's a complicated process. As you can see, I mean, you need to have a competent blastocyst, which is supposed to secrete several molecules, okay? And then the endometrial epithelium, secretes other stuff, okay? So there's an interaction constantly, and then somehow it ends up in implanting, okay? So integrins, intracellular adhesion molecules, growth factors, etc., which we don't know them in totality, okay? So that is endometrial function. If you want to assess endometrial function histologically, you need to take a tissue sample, which we don't do, okay? And even though I have doubts about the effectiveness of the current version, okay, so there are other methods of assessing endometrial function, like looking at gene expressions, etc., okay, which could give us an in-depth understanding. However, what we'll be talking about is a pretty crude surrogate, which is endometrial thickness. You can see it in different ways. One is, it is inexpensive, it is readily available, and it still gives us a lot of information, roughly, but it only gives us information about the size of endometrium rather than its function, probably. Okay. So, on the other hand, it is, you can regard it as a crude measure, with, like controversial association with functions at the molecular level. But anyways, even if we accept it as a readily available, practical, easy-to-use tool for assessing endometrial function, receptivity, let's see how good we are at measuring it. Look at the image. It seems pretty straightforward. Okay. And this is a nice study from Switzerland. It's a prospective study that includes over 1,000 patients undergoing IVF at a single center. I mean, this graph is not it does not represent all 1,000 patients. It's a subset of 23 patients who have been scanned by 2 different doctors 5 minutes apart. Okay? And this is a Bland-Altman graph showing the variations in the differences between the measurements done by 2 different doctors, 5 minutes apart. This is the mean of 2 measurements. Let's say if the 2 measurements, the mean is 9 millimeters, the difference between the 2 doctors' readings could be as high as 3 millimeters. So one would say 7, the other ones would say 10 millimeters. Okay? And a larger subset from the same study, it's the same patient, same doctor, 1 day apart. Okay? Well, obviously, endometrium would grow in a day, but would you expect it to grow as much as 4 millimeters a day? Or even shrink by 2 millimeters a day? I'm sure you have all come across patients, especially when you needed to do consecutive scans, like under risk of ovarian hyperstimulation syndrome, etc. So you sometimes see, get the impression like, you measure the endometrium smaller than the day before, which may make sense or may not, okay? Slightly oblique section, or actually getting smaller, who knows? Then, here's another comparison, histological measurement of endometrial thickness by a ruler. This is a study recently published in the British Journal, women undergoing hysterectomy. Just prior to operation, they do a transvaginal endometrial thickness measurement. Then the pathologist, blinded to the first measurement, cuts the endometrium, measures the endometrium with a ruler. Okay, here are the differences, as big as like 5 millimeters. It's unbelievable. okay? And if you look at the subset of patients who had endometrial thickness less than 5 millimeters histologically, the differences are still as wide as, like 2, 4, 5 millimeters. It's, almost haphazard, okay? So it's not only a crude tool, in my opinion, of endometrial function. We are probably not that good at even measuring it properly, okay, in a reproducible manner. Okay, so how did we end up in kind of being obsessed with endometrial thickness? I was always curious about it from the day I started, learning about ART, and then I chased it up to this paper, which, I admire Dr. Casper very much. He's done, like amazing work throughout the years, and with probably his fellow back then, Yael Gonen. So this was a descriptive study reporting 123 patients who underwent treatment. IVF was new those days, okay, in their center in Toronto over a year. So they wanted to assess if pregnancy rates were associated with endometrial thickness and endometrial pattern. The paper was rejected from Fertility and Sterility, and it's published in this journal, which is known as Journal of Assisted Reproduction and Genetics nowadays. Okay, and they describe the relationship between endometrial pattern and pregnancy rates. And then, of note, we just happened to notice, there were no pregnancies in women who had an endometrial thickness less than 6 millimeters. And now it gets into literature. Less than 7 millimeters, less than 6 millimeters, okay? How many women would you have with an endometrium less than 6 millimeters in a cohort of 123 unselected women? Pay attention to these numbers in the upcoming slides. It would be less than probably less than 2%. So maybe it's only 2 women, okay? Anyways, was this finding confirmed later? This is a systematic review published in 2011, collecting, prospective or retrospective studies reporting endometrial thickness on the day of HCG injection and pregnancy rates. Yes, it is true indeed, women who finally had a pregnancy had statistically significantly thicker endometrium on the day of HCG injection. But if you look at the absolute value, they had an endometrium thicker by 0.4 millimeters on average. Remember the precision of the measurements I showed you. Okay. So, yes. But is it predictive? This is the most recent review on the subject, published in Human Reproduction Update. If you compare clinical pregnancy rates in retrospective or prospective studies between women who had an endometrial thickness equal to or less than 7 millimeters, as opposed to women with endometrial thickness more than 7 millimeters, yes, they are significantly less likely to have a clinical pregnancy. But look at the number of women in this arm, like really less than 5% as expected. And how about live birth rates? Yep. Again, it is hardly significant, okay? Because, there are like few patients. Yes, there's probably something cooking in here, okay? But, it's based on small number of patients. We're talking about a minority, which we come across still every day if you have, many patients enough. So if we happen to accept a thin endometrium is a bad thing, how does it happen? Okay, so this is a nice Japanese study. They observed women on their natural cycles, not stimulated cycles, and categorized them as women having thin endometrium less than 8 millimeters or a normal endometrium thicker than 8 millimeters. They took histological samples and did some analysis, okay? And they also did Doppler measurements. Yes, women with thinner endometrium had higher resistance in blood flow in the spiral arteries. Okay. And in the histological sections, they had less endothelial cells, less vascular formations, so it's less vascularized. Okay. And the VEGF expression was less in thin endometrium. So all suggesting, less vascularization, less circulation, less oxygen, so that's why it cannot grow. That's not why it would be, less receptive to the embryo. Makes sense, right? Here's the other side of the coin, a different perspective. This is from a views and reviews paper by Robert Casper again, who initially introduced the concept. And this image is from 1957. Amazing. Okay. So endometrial cross-section, the basal layer with the radial and spiral arteries, the functional layer with spiral arteries. Okay. So the basal layer is more or less constant. What gets thicker and sheds is the functional layer. So the differences is expected to be at the functional layer. Okay. And other studies have shown, actually, at the time of ovulation, in the early luteal phase, when implantation is expected to occur, right, spiral arteries constrict, and there's less circulation, and there's less oxygen tension probably in endometrium. So maybe too much oxygen is not a good thing, which we know from incubators nowadays. You know, the most recent incubators have lower oxygen tension, and we know embryos grow better in lower oxygen tension. Okay? And so the new theory is when the functional layer is thin, the embryo is closer to these wider vessels, exposed to higher oxygen tension, which is likely toxic to the embryo. So different paradigm. Okay? So thin endometrium is still a bad thing. But, I mean, is it because the oxygen is low? Or is it because the oxygen is too much? Or is it totally irrelevant? Okay? We really have no idea. Okay? So looking at, leave basic science aside and, like day-to-day matters, pragmatic studies. We're doing IVF. We have a patient sitting in front of us. We do the scan. She has a thin endometrium. So what? This is a recent study. I'm just showing it as an example. Okay? So most studies, arbitrary cutoff levels. This is, not that arbitrary. Dr. Casper mentioned 6 or less, so it's 7. Okay. So if these people, these researchers, divide their 463 patients as less than 7, more than 7, the difference in pregnancy rates are significant. But it's also significant if less than 8, more than 8, less than 9, more than 9, less than 10, more than 10. So where do you draw the line? Why 7? Why not 9? Why not 10? Why not 8? Okay? So this doesn't give you information, useful information. Okay? This gives you useful information. These are prospective studies, just as I mentioned in the other talk, looking at the predictive values with proper statistical methods, receiver operative characteristics curves. Okay? Remember, a straight line like this is equal to tossing a coin, just by chance. So this is an Australian study, prospective. This is the ROC curve, 45-degree angle, tossing a coin, endometrial thickness, pregnancy, and it is also same for endometrial volume in this particular study, measured by 3-dimensional ultrasound. The other studies show consistently the same thing. So if you introduce endometrial thickness as a continuous variable into this analysis, it is not informative for pregnancy at all. Okay. If you take a different threshold, though, arbitrarily, it could be different. And this is the 1,000 patients Swiss study I mentioned. These are days relative to ovulation induction, HCG trigger 1 day before, 2 days before, 3 days before. So all patients underwent scans across the cycle. The ones with squares are the patients who got a pregnancy at the end of that cycle. The one with the dots, those who did not get a pregnancy at the end of the cycle. Look at every day how endometrial thickness compares. Okay, almost the same. Okay, and obviously case reports are not informative as studies, but let me show you a few examples from the literature. This is Dr. Sandström, unless I'm wrong, from Sweden. So he analyzed, just like Dr. Casper did years ago, his results and categorized them based on endometrial thickness. He had like 4 patients who had an endometrial thickness, 5 or 6 millimeters, who had an embryo transfer. Look, 50% pregnant, 50% pregnant. Obviously the numbers are very small. Okay, it doesn't preclude pregnancy. Okay. And then this is the lowest I could find in the literature. It's a patient who had hypogonadotrophic hypogonadism. That's an ovulation induction cycle, not an IVF cycle or an IUI cycle. The maximal endometrial thickness is 3 millimeters. Healthy live birth at term, normal birth weight. Okay, so the interval conclusion is, yes, looking at the data, woman who eventually achieve a pregnancy at the end of an IVF cycle has a thicker endometrium by half a millimeter. Okay, but probably there's no lower threshold that certainly precludes pregnancy. 4 millimeters, 3 millimeters, 5 millimeters. Okay, and if we are talking about studies published in the past using prior ultrasound equipment, just like phase follicles, okay, so they may not be that good in assessing endometrial thickness, pattern, cavity. And if they did not have additional evaluation, some of these patients with very thin endometrium could be actually suffering from adhesions, in my opinion. Okay. So how about in IUI cycles, pertinent to this particular meeting? There are studies looking at this. This is a recent retrospective analysis from the US, which is nice. And they broke down their patients based on arbitrary endometrial thickness categories, 6 millimeters or less, 6 to 9, arbitrarily defined as optimal, or more than 9 millimeters on day of HCG. Okay, there are some reports suggesting, thicker endometrium is associated with worse outcome as well. Okay, and when they take the 6 to 9 millimeters as the reference, there is no significant difference in adjusted analysis in pregnancy rates in IUI cycles based on endometrial thickness. And the authors did a review of the studies published that far. And this is the one actually I like the most. There are 2 retrospective and 2 prospective studies with, different results. The prospective study, this one suggests actually endometrial thickness was higher in women who got a pregnancy. But this one I really like more, not arbitrarily, because if you read the full text of the paper, this is by Stratis, they prospectively measured endometrial thickness like 5 times for each patient, then took the average value, just like doing some obstetric measurements like abdominal circumference. No one measurement is, perfect. So if you measure it, over and over, you'll approach the true value. Okay. So in my opinion, this is methodologically the best study, and it suggests there's no association, no clear cutoff for endometrial thickness in IUI cycles. Okay. But then those are clomiphene or gonadotropin cycles. I compiled studies reporting, endometrial thickness in clomiphene-induced or aromatase inhibitor-induced cycles. And actually, if you're concerned with a thin endometrium in a clomiphene cycle, if you switch to an aromatase inhibitor, yes, you'll more likely have a thicker endometrium if that's what you want. Okay, so we've been through, the effect of thin endometrium, the imprecision or precision of our measurements, possible mechanisms and pragmatic results, associations in IVF and IUI cycles. And if you think you need to do something with a thin endometrium as you define it, so what are the alternatives that have been tried and published so far? There's the, aspirin as always, and all these ones, and I'll review them one by one, just to save time. Okay? So this is a study from 1997. It's a randomized controlled trial. It included women, oocyte recipients actually, who had a thin endometrium in a prior cycle. Okay? So they were randomized to receive baby aspirin or nothing. The week before they started estradiol replacement for oocyte donation. Change in endometrial thickness was, more in the aspirin group, slightly. And unless the researchers were blinded, this is, I would say, could be, subconsciously biased, but it wasn't statistically significant. Overall, live birth rates were not significant. Implantation rates were better, despite almost statistically similar endometrial thickness. And if you analyze a subset of patients who still had endometrial thickness less than 8 millimeters despite the randomization in the second cycle, Yes, live birth rates, I mean, I would say they would be clinically significant if maintained in a larger sample. Okay. How about IUI? There's a study in IUI cycles also. Women who had a thin endometrium in a prior cycle given aspirin versus no aspirin. Nothing changes except for the proportion of women who had a trilaminar, nice endometrial pattern, but the thickness is the same. Okay. And the pregnancy rate is almost twice in the aspirin group. Okay, statistically significant. I'll show you a summary table at the end, but this is only one study, not being replicated in a similar setting. So despite being a randomized controlled trial, I mean, from an evidence-based medicine standpoint, this would constitute, at best, low to moderate quality evidence for effectiveness of aspirin in this setting. The other option is pentoxifylline and tocopherol. Pentoxifylline is a vasodilator. It's shown to increase red cell deformability, decreases platelet aggregation, antagonizes tumor necrosis factor alpha. And now that may be surprising, decreases colon-stimulating factor level, which we'll review later on, which is supposed to be a good thing. And tocopherol, vitamin E, is an antioxidant. The studies I'll show you now is done on women who have received pelvic radiation for oncological treatment. These are not regular, patients with a thin endometrium. Okay, they received pelvic radiation, had atrophic uteri, and thin endometrium. And these are two uncontrolled case series, including only 38 women. They were put on varying dosages of pentoxifylline and tocopherol for 6 months. And their endometrial thickness were significantly increased in both studies by 1.3 and 1.6 millimeters. But even though it was increased from an average of 4.5 to an average of 6 millimeters, so it's still thin by these definitions. And in 27% live birth, 6 live births in this study, and 3 of them were spontaneous, and 40% pregnancies, again almost half spontaneous in the second study. From an evidence-based standpoint, this is a unique population who underwent pelvic irradiation. Okay. So, technically, strictly speaking, it's not generalizable to the regular patient. And 2 uncontrolled case series, that constitutes very low quality evidence. Another popular option, sildenafil, Viagra, a phosphodiesterase inhibitor, supposed to cause vasodilatation. And if you think vasodilatation is a good thing, then it may be a good thing. And it was first introduced by Jeffrey Sher, and in a case series of 4, then another case series of like 20-something, and eventually a study including 105 women. So all these women had endometrial thickness less than 8 millimeters in a prior cycle. They were given 4 times Viagra tablets vaginally versus nothing, okay? And at the end, even though endometrial thickness was the same, implantation rate was found to be significantly increased. There are several things, okay? One is, assessing the generalizability of any study. We need to look at the absolute numbers. In any study, not for this particular study, let's say comparing a type of luteal support with another type of luteal support. In studies reporting significant differences, usually I find, the event rates in the control groups extremely low, okay, like 2% implantation rate. Okay, so is this representative of the general patient with thin endometrium? I don't know. Even though I wasn't able to access the full text, Jerome Check published another randomized controlled trial with the same protocol, similar patients, and he reported ineffective. So one effective, one ineffective, one, like a subset of one of the variables measured, okay? So I would say low quality evidence, maybe. L-arginine, another antioxidant, okay? So again, who had a thin endometrium, right? And this is technically not a great study, because to have proper statistical power, you shouldn't divide your patients into numerous groups. Then you wouldn't know which one to compare. You would always have low power, etc. So as one control group, one vitamin E, one L-arginine, one sildenafil with all like almost at most 25 patients. So it's not really a great study, okay? And obviously has limited power. Yes, endometrial thickness seems to be increased with L-arginine, okay? Number of pregnancies, not really. Okay. This is very, very low quality evidence.
So 2 minutes more, sir. 2 minutes more.
Okay, 2 minutes, fine. The other study, GnRH analog luteal support starting from day of oocyte collection, embryo transfer, and 3 days later. This has been tried in other settings, but this is the only rationale is if there are GnRH receptors on the endometrium, so why don't I try to stimulate them? Okay, and patients with a thin endometrium in the prior cycle, okay, so live birth rate again significantly increased with GnRH agonist luteal support almost 6 times, okay. I still have the same question for the, like generalizability of the control group, even though this is a, like comparative study. Briefly summarizing estradiol, okay, if you're doing a frozen embryo transfer or adding estradiol on top of your stimulation, okay. Increasing estradiol dosage, using in a stepwise fashion, using it orally or vaginally in general based on literature finding doesn't make a difference. Okay. Extending the exposure to estradiol may provide some improvement in endometrial thickness. It certainly, almost certainly does not harm receptivity, does not harm implantation rates or live birth rates, but whether it improves in this setting is questionable. Same for vaginal estradiol. And again, similar to GnRH analog, there are HCG receptors in endometrial epithelium. So people thought if we stimulate them with a paracrine activity, could we get a more receptive endometrium? So it's like this is a study published recently in the Journal of Reproduction and Genetics. It's again an uncontrolled case series, women who had 2 negative IVF cycles, thin endometrium consistently, normal endometrial cavity, put on an incremental estradiol protocol, and they were given 150 units a day HCG systemically, starting from the 8th day until the 14th, 15th day of endometrial preparation. Then it was stopped and the patient was put on progesterone, endometrium got thicker, and actually it got 10% thicker in 50% of the patients. So what does it mean? 10% means 6.6 from 6, 7.7 from 7. So these are all arbitrary outcome measures. And this is the pregnancy rates, 50% and 40% live birth rate. It is impressive, but it's uncontrolled, very low quality evidence. And to make things more confusing, there's a prior study which has I would say, a very good design. So these are oocyte recipients, okay, and sibling oocyte recipients, same oocytes from the same donor from the same cycle, randomized into receiving a higher dose of systemic HCG every 3 days, okay, versus no HCG. Indeed, surprisingly, they had thinner endometrium on HCG, unacceptably low pregnancy rates and implantation rates, and the investigators in Thessaloniki stopped the trial after inclusion of 22 patients. Okay, so controversial results could be depending on the dosage, timing, etc., but nothing so far. Granulocyte colon stimulating factor. Remember, I was talking about pentoxifylline. It was supposed to decrease colon stimulating factor, but Norbert Gleicher reported that colon stimulating factor could be a good thing. So he had some patients who had thin endometrium, so he gave them intrauterine infusion of colon stimulating factor. So of those 25 patients, 4 conceived, they had thicker endometrium, okay? Uncontrolled case series, fine. And then this is a similar study in frozen embryo transfer cycles, so not really a benefit, but as Norbert Gleicher observed, a beneficial effect in women, those 25 women with a thin endometrium, and they got higher pregnancy rates without getting thicker endometrium. So the deduction was, if it functionally improves endometrium, would it increase the chance of pregnancy in the regular patient? So they did a randomized control trial, crossover, in the second phase, okay? And with all these cycles, I mean, colon-stimulating factor infusion at the time of HCG injection did not improve endometrial thickness, implantation rate, pregnancy rate, live birth rate, okay? So I would say, in general, high quality, almost, I mean, at least moderate to high quality evidence that it's ineffective. Autologous platelet-rich plasma, aesthetic surgeons love this, okay? So you draw some, I mean, blood sample from the patient herself, okay? And then coagulate it, activate the platelets, which secrete, you know, a lot of growth factors, cytokines, etc. Then you put it on wherever you want. I mean, whether like to treat acne scars, okay? Or, I mean, surgical scars, whatever, or if you know, like put it in endometrium, maybe those factors would stimulate endometrial function. I mean, look at the only publication I was able to trace, 5 women who had a prior canceled cycle due to thin endometrium, okay? So they underwent autologous platelet-rich plasma infusion, intrauterine infusion, and it was repeated if endometrium in 3 days, if endometrium was still thin, and after 2 infusions, all women had thicker endometrium, and all were pregnant. They only had 1 miscarriage, which was found to be chromosomally abnormal, nothing to do with endometrium. Okay, so yes, it is encouraging, but remember the initial reports with Viagra, and remember the initial reports with colon-stimulating factor. So we need to see if this survives a randomized controlled trial, and we also need to see its safety profile. Okay, but so far that's the only thing. Now that's my second from the last slide. These are 2 nice papers coming from Australia. So thin endometrium, they found in a retrospective analysis is actually associated with higher risk of ectopic pregnancy. Okay. And a thick endometrium, or is the other way around, okay, anyways, is associated with a risk of placenta previa. Okay. And this includes like more than 5,000 cycles, I mean robust data. Okay. So there are a lot of things we still don't know about it. It is probably has a functional relevance, okay, but whether it affects, I mean, the bottom line is there is something relevant to endometrial thickness, obviously, okay. But how good we are at measuring it, and if we are convinced, so I mean, like placenta previa is a very rare event, ectopic pregnancy is a very rare event, but we do not have any proven treatment for a thin endometrium for the purpose of increasing implantation and live birth rates. So I would agree with the Human Reproduction Update paper published 2 years ago, okay? So, and I personally do it in my clinical practice. I do not cancel cycles based on endometrial thickness. Okay? I transfer embryos, and I don't put my patients on any of these. But I mean, if any of you do, I think it is legitimate. I mean, none of these are like absolutely proven ineffective. But we need to be, you know, open to the patient, you know, explain, you know, the options, the relevance, etc., and take into account her choices as well. And as most of these things, with the exception of, I would say, you know, this is expensive, this I don't feel comfortable. But these other stuff, you know, these are inexpensive. I mean, if she feels more comfortable using it, if she asks for it, I agree, but I do not routinely recommend. Okay. Thank you for your attention.